my friends were making fun of me, this long tagline that I have on my intro slide, but I felt like I needed to develop a little street cred to hopefully make this next hour worth your time for everyone that's joining us tonight. So thank you for having me, and thank you for everyone for joining. Kind of along the lines of like that kind of developing street cred. Let me give you a little bit of background about who I am and like what I've done in the point of care ultrasound world. And first and foremost, I've had it easy probably compared to a lot of you. I unfortunately I can't see, who's with me today and what specialties, but hopefully we'll get a chance to talk about like where you're at as far as specialties, where you practice and whatnot. But like EM, I was fortunate. I've been practicing emergency medicine now for 10, 12 years, something like that. And when I went into residency, point of care ultrasound was already well established. We have literature back from like the late 80s, early 90s about point of care. We have policy statements from our national societies from like the early 90s. And that as of like right the beginning of 2000, ACEPT, our emergency medicine college, put out guidelines and really kind of spearheaded, point of care ultrasound and what our skill sets are, credentialing, things like that, ACGME requirements. So by the time I came along, point of care was really well established in emergency medicine, especially at my institution. Tom Constantino was my mentor, and he had been already practicing for over a decade doing point of care. He had set up an incredible POCUS educational and clinical environment within our Department of Emergency Medicine, and kudos to him, but also to our chair who really was instrumental in requiring all faculty to be credentialed in point of care. And it really was just um, pretty much a given that we had this in our department. So I really didn't have any trouble or difficulty or experience setting up point of care within an emergency medicine department. But since then, I've had a lot of experience trying to expand our capabilities within the departments, including like transesophageal echo. I've had experiencing setting up point of care curriculum for our internal medicine and family medicine programs, and starting one of the first internal medicine POCUS fellowships at Temple University. And then I chaired our POCUS health system committee that really kind of moved POCUS billing, credentialing, things like that outside of the emergency room system wide to multiple different departments. And then finally, I've introduced point of care ultrasound education into our medical school, and really oversee an entire 4-year curriculum. So I've had pretty good experience, and I've probably experienced a lot of the frustrations, the questions, the obstacles that many of you may have faced thus far. And hopefully, some of what I'll talk about tonight answer some of these questions. But I'm going to leave a lot of time at the end to like answer your questions. Please take my email. I am more than happy to chat over email. I can give you my phone number and whatnot. Like, I am a firm believer in the power of POCUS. So, without further ado, we'll get started. Disclosures. Obviously, we know who's asked me to be here tonight, but otherwise, I have no other disclosures. Nobody's paying me to do anything, and I've really no skin in the game as far as any sort of POCUS, institutions, certifications, things like that. I'll give you my opinion on them, for better or worse. Um, you know, Before I kind of get into the objectives today, the one thing, if you can take away from this, and I didn't start this way by any means, but start small and have patience, because it is going to be an uphill battle. I think it's probably easier now than it has been before with so many specialties adopting point of care, but nonetheless, it is going to be an uphill battle. And really just start with small little things to kind of build those small wins. I remember when I first tried to incorporate the curriculum at our med school. I came in, I mean, I had, I think, a 10-page proposal 4-year curriculum. I mean, super integrated in everything they're doing. I had an honors program. I mean, I was hyped and I was like, the leadership's going to love this. They're going to do it right away. Everything's going to come true. And they were like, you can have an hour during anatomy. And that was about it. And, that was back in 2016. And slowly, as you kind of prove yourself and show the benefits, now this is obviously specifically related to the medical school, um, you know, it starts to expand. And now 10 years later, hopefully it won't be this long for anyone else here, but 10 years later, we do have a 4-year longitudinal curriculum across all 4 years of med school, both preclinical and clinical, and really has grown. But again, it took a lot of time, a lot of effort, a lot of patience. And as an emergency medicine physician, I don't always have the most patience. So I encourage you, if you don't take anything away from this talk, except start small and have a lot of patience when you're doing this. All right, so objectives for tonight. I am not really going to spend too much time on the why. I think if you're here listening to this, you already understand the why. Why are we doing POCUS? I think you all have the answer to that. I'll have one slide on that. We'll talk about logistics. I think that's one of the biggest challenges because even though you're passionate about it and it's the right thing to do for the patient, not everybody always sees it that way. We'll talk about the equipment that you need, the training. You're going to need to set up quality assurance alongside of the training aspect. And then we'll touch on credentialing as well. And a lot of these, certifications that some for-profit companies have taken advantage of. And I think you probably can already tell from that comment, I'm not in entire agreement with that kind of approach. So this is kind of where we're going to head. Again, though, hopefully at the end we'll leave a lot of time for like questions that you have, because a lot of times, depending if you're inpatient, outpatient, what specialty, what kind of support your hospital already has, a lot of the challenges can be very individualistic. Although there's some overarching themes. So, real quick, the why, I think we all know it. It is an incredibly safe and accurate diagnostic imaging modality, obviously, in an appropriately trained individual. It really kind of changes our bedside evaluation of patients as far as physical exam, differential diagnosis, treatment plan, and actually the safety of procedures. Obviously, there's no radiation. It expedites care. And one of the big things that you can sell with your big wigs is it does improve patient satisfaction. There is evidence out there that it does indeed, because they're actually seeing something at the bedside. You can show them the images right there, and a happy patient goes a long way with some of the C-suite folks that may not truly understand why we need to donate or put aside money for this endeavor, because it does get expensive. I'm not going to say anything else beside from this slide regarding why POCUS, because again, I think if you're here, you already see the value of it, and now you're getting to the point of like, how do we do this? Certainly, I'm happy to answer any questions, study specific, with point of care at the end, but I didn't want to really kind of belabor that point. Because I think one of the biggest challenges is going to be this room right here. I think every institution, health system, clinic is really feeling the crunch as far as financial burden and what we're doing. We're doing more with less. And why should we put money towards expensive equipment and training and things like that? So you're really going to need to prove the return on investment here, because it's going to be a lot. Like, you're going to be involving IT, you're going to need billing, you're going to need credentialing, and you're going to need biomed, in addition to equipment, maintenance, purchasing, training, things like that. So there's a lot that goes into this. Aside from the patient satisfaction argument, we get into, I think, if you do get to this, or when you do get to this point, billing is going to be your best friend. I'm not going to go into the specifics of billing as far as, how much for each scan can you get. But there are two components to billing. There's a professional billing, and there's a technical billing. So professional billing is you as the physician interpreting it. You would think that that'd be much more lucrative, but it's actually the technical one performing the scan that actually typically bills three times as much. So this is something that we've done routinely where we'll show at the end of the year how much we billed. And then certainly, obviously, it's not what we collected, but what we've shown year after year is that what we are collecting far exceeds any of the equipment purchasing, training, things like that, and the ancillary staff that it is that helps us keep our POCUS um, division up and running. So working closely with billing and getting both professional and technical billing down is going to be your best friend really convincing the higher ups that this is worth an initial investment because they will make money back on it um, in the long in actually a very short term if you get this up and running. So one thing, that also helps, especially if you're in a academic center, is now we have numerous, well beyond just the one that used to be emergency medicine, we have numerous residencies that there is an ACGME requirement mandating point of care ultrasound training within the residencies. Now, it varies widely, how much, is required and what the definitions of all these different requirements are, but these are the specialties so far that actually have ACGME requirements. So part of this is really trying to formulate a team here to work together because if you can bring multiple departments, it'll kind of defray the cost as you're starting to get this up and running. And what I like to do when I was putting together the ultrasound curriculum at the med school, I kind of like secretly shamed our med school into being like, hey, look what Penn's doing, look what UC Irvine like. So a lot of this is like, hey, other people are doing this. It's been successful. And that does tend to get some movement in the people that make decisions regarding purchasing and things like that. But the one thing I would strongly advise you to do is to collaborate with these departments to see what their needs are, to see where they're at as far as their training goes. If you're at a place with emergency medicine, they should be really well versed in this and really can help get you up and running. And that's what we did at Temple with our family medicine, internal medicine, and gen surge. We found one or two individuals in each department that were really passionate about it, that understood the value. And then we started training with them and we slowly incorporated longitudinal curriculums. We formulated a POCUS committee within the health system that really helped us get IT and billing and credentialing all under the same page, with expanding it well beyond the emergency medicine department. So think about, specialties outside of yours to collaborate with, and that really does go a long way as far as getting support behind this. All right, so I mentioned all the different specialties. One of the biggest questions I get is about credentialing, training, and what is the requirement here? I really wanted to put this up because a lot of ultrasound organizations will quote this. It is the AMA policy statement 802 that was last modified in 2020. You don't need to read this. I hate having slides where you have to read stuff, but basically what it's saying is that the AMA agrees that point of care ultrasound is within the scope of practice of appropriately trained physicians, and these specialties should be making the decisions as far as training and education standards. So this shouldn't, and this kind of will fold into when I bring up these for-profit certifications that are out there with RDMS and things like that. They will get a lot of push into your hospitals, and they will be asking, showing that there's value in them, but there's a lot of cost to that, and that can be prohibitive. The point being is this is one of the arguments that you can use, that it is specialty specific. It is something that your specialty really should um, lead as far as credentialing go. Well, credentialing is a local thing, but training and education, and that way some of these for-profit certifications will not be, your hospital won't be inclined to kind of force you down that avenue because it really should be within internal medicine, emergency medicine, things like that. And the AMA fully supports this. And that's how we've kind of moved forward with our departments outside of emergency medicine, showing that, we don't need these, third party certifications. Like we can provide our own training and oversight within the hospital, within the department. And that really defrays a cost because a lot of these outside certifications have initial fees to get training. They have examination fees, and then they have like recertification fees, annual fees. It really starts adding up, and you're like, what's going on here? So um, this really advocates for the individual specialty to dictate the type of training and education. So kind of moving a little bit beyond, credentialing and things like that. Once you're at the point where you're getting equipment, there is innumerable options out there. And depending where you're at, depending what your resources are, you may be able to have a traditional cart-based model. Typically, they'll run you anywhere from like 30 to 50,000. Um, but these newer handheld devices that have come out, and I don't have any sort of disclosure about any one of them. I've used the V-scan in the middle here. I've used the butterfly. I've used Clarius. They all have their advantages and disadvantages, but I think the best thing about them is their cost comparatively to the traditional cart-based machines. This is what we used in our internal medicine department because it was just prohibitively expensive to try to have machines on each floor or in each clinic. So we were able to utilize handheld ultrasounds, and they're at the point, all these companies, whichever one you do decide to choose based off of your needs, will integrate with your image storage and your billing and things like that. So there's not a lot of IT component that heavy lifting that you'll need to do. It's more or less, what do you need it for? Costs are fairly similar, anywhere from 2,500 to 5,000 for a single probe, but a lot of these will give you, if you're buying in bulk, will give you discounts. Like we bought handhelds for our medical students, and we got a big discount there. Again, this goes back to looking in other departments, seeing what their needs are, and really kind of coming together to kind of defray that cost. That usually is what the rate limiting step for a lot of the finance people back there. But you can ask specific questions because, like, I've used all of these different models. There's a Sonosite down there. There's the GE up in the top left. Like I said, the Butterfly, the V-Scan. We conducted a study at Temple comparing handheld ultrasound with traditional cart-based models. And what I will say is, obviously a $50,000 machine has much better image quality than a $2,000 one, but we were able to show they had the same diagnostic capabilities. So when we looked at gallbladders or aortas or, looking at ejection fraction, we were able to yield the same results. And then one of the secondary outcomes was just image quality, which we already kind of knew. So they are, getting better by the day and are really a great option and a cost-effective option to get your point of care program up and running. And I'm happy to answer more about equipment stuff. But again, I think that's a lot of like what your needs are and what type of resources you already have and money available to spend, and that kind of dictates. But I think the handhelds do a nice job. Outside of a combined department like emergency medicine, like if you're running around on the floors, I think it really does a nice job. A clinic, you might be able to get away if you do have the money with a traditional machine. Again, it's all very individual as far as equipment purchasing goes. All right, so training and development and these certificates. So like I mentioned before, the AMA Resolution 802 dictates that training comes from your specialty. So please, I would encourage you not to pursue any of these unnecessary pay for trainings. They are incredibly expensive. And you don't need them. Your specialty societies, the annual meetings and things like that, all have point of care, or most of them do, family medicine, internal medicine, things like that, have training and education opportunities that aren't requiring these yearly maintenance fees and things like that. So um, I would encourage you to look towards your specialty societies to for guidance as far as specific training and education opportunities, and try to avoid some of these pay for certifications. Um, Resources, again, a lot of this should come from your own medical specialty, but a couple of the ones that I think are kind of broadly applicable. I put ACEP up here, the American College of Emergency Physicians, solely because they've been at it for so long. And in all honesty, there is absolutely no need to reinvent the wheel when you're doing this. I think that is a great starting point if your specialty doesn't have formal guidance yet as far as training, education on point of care, and really what type of scans fall under your purview. I think ACEP, at least starting there to kind of see how to develop guidelines, that is a great starting point here. The other institution that I will recommend is AIUM. I served different committees on AIUM, and they are a multi-specialty society that really just focuses on the practice of ultrasound in medicine. And they have very specialty specific ultrasound to point of care ultrasound. It really kind of runs the gamut. But I think a lot of the benefit there is that it brings together multiple specialties in point of care, particularly family medicine, internal medicine. Our internal medicine fellowship director has been doing a lot with them now. And it's really a place for collaboration. And they have a lot of guidelines that you can go off of to help kind of establish where you're going. Interestingly enough, both ACEP and AIUM do have certifications that you can pay to get. Um, I personally do not recommend them. I, again, think you should stick with your specialty societies for training. I don't think you should pay for a certification unless it's a board certification from whatever specialty you are. ABEM, the American Board of Emergency Medicine, has a focus practice designation now with ultrasound, and that is something that I did get. It's a requirement to be a fellowship director, and that's what I was for a while. But I would caution pursuing, some of these ones that you pay for. But I think nonetheless, these two organizations have great resources as far as guidelines go. Um, Again, in the same vein, as far as like not reinventing the wheel, like when I first started out, I was like, oh, I got to develop my own content. I want to be out there and all, and it's just not worth the time and effort. There's so much great content out there that will, educational content, and advanced content. Core ultrasound is probably the best one. I have no stake in that one. I would love to have a stake in that. There were three different websites that came together, and they just have just super high yield training videos. They actually have in-person training. They have cases of the week. They have podcasts. They have journal clubs. I mean, you really can go from very basic point of care to like some of the most advanced point of care that you'll do out there. The POCUS Atlas is also a free uh, resource that really will give you just a huge catalog of normals, abnormals, and things like that. If you're ever developing lectures or you need examples of things, it has a lot of great educational content. There is a ton of other ones out there, but they're two of I think, the most high yield um, educational resources. And again, try not to, focus your time too much on developing content or guidelines and things like that. Use the resources that are already out there and move from there. Um, that's really the kind of the biggest things I wanted to focus on tonight, because I really want to give time for questions and whatnot. But again, Start small. It's going to take time. You're going to need patience. You guys are going to be the champion in whatever specialty you are, but please try to find other champions to collaborate with because that's going to really defray the cost because that's really what's going to limit um, a lot of institutions adopting this, despite so much, I mean, overwhelming evidence that that's the right thing for the patient. Money is the rate limiting step most of the time. So again, starting small, collaborating is really the way to go. Again, like I said, I'm more than happy to be a resource. You know, I've been around the block doing this for quite some time. I've had my own, headaches and failures and successes and whatnot. Um, but that's really kind of what I wanted to focus on tonight. My email again, please feel free to take it down and email anytime. I'm happy to collaborate any way I can. Um, and at this point, I think it would be most helpful to do some question and answers if anyone has anyone. I haven't been able to see the any of the chat box here, but more than happy to answer specific questions.
Thank you so much, Dr. Gibbons. That was really interesting. And thank you for making such an interesting case for how to get through some of those economic concerns when it comes to purchasing one of these machines and offering that service. And yeah, we are now open for questions. We don't have any questions yet, but please, we invite you to go ahead and enter them at the bottom of your chat. And we'd love to get that question over to Dr. Gibbons. In the meantime, Dr. Gibbons, I did have a question for you. What obstacles have you faced in implanting POC ultrasound in your clinical practice, implementing?
So I would say probably the biggest one is unfortunately like faculty and physicians um not wanting to adopt it, not seeing the value behind it, and really kind of dismissing it, which I understand. I mean, it's a lot of effort to learn this. I mean, I've done thousands and thousands and thousands of scans, and it's a lot. Like, and it's time consuming in a sense. You have to go get the machine. You're doing it and interpreting it. It's a lot easier to just order it and let someone else do it and interpret it and whatnot. So I think just resistance to adopting it, and that's you're going to get that regardless of with any new someone. Not that point of care is that new, but like I think you're going to face that no matter what. And those individuals, I don't think I would put a lot of time and effort into. It's the ones that that really understand it and get it that I would latch on to because like one of our trauma surgeons really saw the value of it and we've collaborated a ton as far as moving point of care throughout the general surgery curriculum. Same thing with medicine, and then our new vice chair of in family medicine. I mean, first thing he was when he got here, he's like, "How do we get this up and running?" So look for the people that are ready to adopt it and understand the value. And then there's going to be money's always going to be an issue. And then one thing as you get into this, and I didn't really want to get in the weeds on this, sterilization, and disinfection and stuff like that, that will become an issue depending what you're using your point of care for, especially if it's procedural. I didn't really think it was worthwhile to go into that tonight, but that is another challenge, especially when we do like endocavitary for first trimester pregnancy. We do transesophageal echo in the emergency room. Those need high level disinfection, and that was a lot of effort to get the hospital to buy into it and get a process that worked. Um, but again, I think that's beyond the scope of tonight. But that was another one. So again, I think it's people not adopting and money are gonna be your biggest issues, or were mine at least.
Thank you. Interesting. And we do have some other questions that have come in. What is butterfly good for? This is from Lynn Cintron.
Uh, Honestly, the beauty behind Butterfly, they have new technology. Please don't ask me how they did it. It's a trade secret, apparently. But they were able to basically combine all probes into one. So the value behind that is, you don't have three different probes on a machine. So you have, your cardiac setting, you have your vascular setting and or linear, and you have your abdominal or curvilinear settings that you can just honestly with on your iPad or whatever smartphone, you can just toggle between them. So really its use is pretty ubiquitous as far as what it can do. The limitations, the image quality is not quite there, but it's continues to get better. Um, it has a bigger footprint, so with cardiac, it's a little bit more difficult than a traditional phased array probe. But I think, like I said, for our internal medicine and family medicine departments, that's what we got because it was cost effective, and for what they were starting to do, it was a great option because it's very cost effective, and it's handheld, and you can move about the hospital without having to drag around, that one $50,000 machine. So, yeah, the only other issue with the butterfly is it can overheat. So, that's just one thought. But if you're looking at handhelds, I would look at them all and kind of compare, what your needs are, because they all have their pluses and minuses, but they're all smartphone friendly and a great alternative in all honesty.
Thank you. And this next question, at what point do you start billing for POCUS? I've done a total of 6 GBUS and found 2 people with gallstones. Is it appropriate to bill for those even with such limited experience? That's a good question.
So that all like billing ends up being a local issue. So I had a similar question the other day from from one of my buddies at a different hospital. I mean, if you're credentialed to do something, which if you're doing this and making clinical decisions off of this, then you should be able to bill for it. Now sometimes they don't talk to one another as far as, like when you're entering it in the medical record, does it, and then you get into like, um, do you, does it, like, well, billing, again, I would say billing is a local issue. If you're credentialed to do it, then you should bill for it, is what I would say. And you'll need to talk to billing about that. But again, like 6 scans, again, that's departmental, like who credentialed you. If your department has credentialed you to do gallbladder ultrasound, um, and you're making clinical decisions off of it, then technically you can bill for it. And the next step would be to talk to billing. And then you also have to talk to whatever electronic medical record, IT, to actually, once you put that order in, you know, for a gallbladder ultrasound, that it generates a bill once you interpret it. Um, again, though, if it's you're just kind of doing it to, and not documenting it in the medical record and you're not credentialed in it, then obviously don't bill for it. As far as emergency medicine, we require 25 scans of any particular application to be credentialed. But we also have the QA, and I apologize, I completely forgot to mention the QA process, because QA, we review all our scans weekly in the emergency department to make sure that, faculty and residents aren't missing anything, that the scans are appropriate, and we give them feedback. Is that mandatory? I mean, for emergency medicine, it is. I don't have the answer because and I don't think it is for any other specialty at this point because I don't think they're as well established. Um, but yeah, to answer your question, if you are credentialed, you're making medical decisions and documenting it in the record, then you could bill for it.
Thanks, Dr.
Hopefully that
Givens.
answered that.
Yeah. Any experience or suggestions for implementing POCUS for EMS? Chris Sims.
That is a great question. I have very little experience. I think. I've heard about it. I think it's we should be doing this. I'm not an EMS guy, so yeah, I haven't done anything specifically. I know one of our neighboring hospitals or health systems, Cooper, over in Camden, New Jersey, their EMS does it. I don't know what their, the extent to, what type of applications, but I think, and I've seen literature on it. I think it should be because I think you know, like venous access would be a great one. Even looking at the heart or for pneumothoraces, like there's things that, emergent things in the field that they might need it for. And I think under the appropriate guidance and training, um, you know, people are more than capable. I think we kind of got stuck on like, oh, it's only techs that can do this, but we can all learn a skill set, and as long as we're doing it safely and know our own limitations and we have the appropriate guidance, I think EMS is definitely um, the next step for point of care, and they're already doing it. I just personally don't have any experience with it. Philadelphia is it's just too much of a you probably have to start individually at very specific houses and maybe build from there. It's just probably starting in smaller, counties and things like that would be a little bit more feasible.
Thank you. This question from Carmen Kahina. How do you navigate situations where faculty are not yet comfortable with POCUS, especially when trying to integrate it into trainees' clinical decision making? At times, I find findings that could impact management, but if the attending doesn't fully recognize the value of POCUS, they often defer to radiology instead.
Um, yeah, it sounds like you might be a resident. I'm not 100% sure, but I can feel your pain because even when I was, and I'm sorry if I'm assuming you're a resident, you're not, but like when I was a resident, when I was off service, it was the same way. I'm like, I just, diagnose this and they're like, well, I don't like, um, unfortunately, it's going to take time. It's in retrospect now. Like I remember when I was in my ICU rotation, they thought I was insane, like with running around with the ultrasound machine. And now they're credentialed in point of care. Some of them are getting echo boarded. I mean, they went from 0 to 60, within a number of years. Um, what I would recommend, because like if you are in training right now, nothing's going to change that quickly by the time you're gone or complete at residency. What I would say is if you have the opportunity to scan and you're scanning, continue to do so, because the only way to get good at this is to scan, 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 and scan. And then look at it as an opportunity that, like, hey, if they get a radiology ultrasound, then compare your findings with their findings. And you're building confidence there. And hopefully at the next place you'll go, you'll be credentialed. You might be the one teaching it from there. We still face that a lot with the majority of our specialists, like internal medicine and family medicine, where we only have a handful of docs that feel comfortable with it. And students coming on, residents coming on, it's going to be limited. But I wouldn't let that discourage you from continuing to practice, because you're going to be the change that happens at the next place to bring it, to the next training place, or if you work out in the community, whatever you do, you'll be that person that is the champion and moves from there. So keep practicing, and then use it as a way to compare your scans with radiology is what I would do.
And Dr. Gibbons, Dr. Carmen Kahina is a resident. So
Okay. What
yeah.
specialty?
Oh, what specialty? Please tell us. Let's see if it comes up. Let's see. Oh, I am.
I am. Yeah, no, and again, it's that it's the same way at Temple right now. Like even though we have a fellowship director, we are on our second or third year of a fellowship now. And we've had two faculty stay, so now we have three. I help out. They come to our, like, if you're at a place that has an emergency medicine residency, see if you can, get opportunities to collaborate with them to go to their QA sessions, because they come to our QA sessions. They'll come down and scan in the emergency room. You might even be able to do an elective in the emergency room with ultrasound. There's ways to get around it. And again, hopefully you're the next person, like I said, when you go to wherever you practice, you'll be the point of care person. And like I said, you want to come to Temple for IM fellowship, POCUS. Well, we're glad to have you. You got my email. There's other, like Penn has one, there's a bunch of them. And that's how it starts. It's a little bit, you have to pay it forward and kind of struggle through it right now, but there's definitely ways to, just keep practicing. And certainly, you can email me offline, as well.
And I have included Dr. Gibbons's email in our chat to everyone. I'll repost it in a little while, but it is there if anyone wants to go ahead and copy and paste it into your own platform or email or contacts. This next question from Rupert Dalla: is there a specific machine that you would recommend for a beginner in MSK US?
Um, For MSK specifically, you'll want a linear or vascular probe. So if you're limited as far as funds go, like a GEV scan has the option where you can have like it's a small handheld that one side is either your curvilinear or phased array, and the other side is a linear one, because that's going to give you the best image quality when you come with it, because you're going to want to look at tendons and nerves and things like that. You're going to want something with the best image quality, and that's your linear probe. So if money is an issue, then I would go with a V scan, because that gives you an option. It's handheld, it's cost effective, and the image quality, because that's still a traditional, the way it's designed with crystals and things like that, which I'm not going to get into. That's still a traditional probe. It's just wireless. So yeah, if all you're doing is MSK and money's an issue, like get a V scan and hook it up to your iPad or iPhone or whatever you carry around, and you'll be good to go. And there are a ton of like MSK resources out there that are just phenomenal. Yeah, you can email me and I can look it up, because I don't have the name of it off my. It's a text that's now online now that I use all the time for MSK, because it's not something I do a ton of compared to like some of our sports med guys. Um, but yeah, simple answer, a linear probe like a V scan. But if you're getting a traditional machine, it doesn't matter, because go with whatever you would, try a few out, whatever you like, because they'll come with the three probes standard anyway. So if you have that kind of money, great. If you want to save a little money, do the V scan on your smartphone, and with a linear probe, and you'll be good to go.
Thank you. And this one from John Fetterbush: do you have any comments about Eagle View ultrasound?
Oh, you stumped me. I'm gonna have to Google this afterwards. I don't know what that is. Is that like a type of machine? I've never heard of it. Yeah. Yeah.
Oh,
I'm sorry. I don't. Yeah. I don't know Eagle View. I'll look it up, and you can always email me. But yeah, I'm not sure.
it's a handheld, helped me with DX SVT of, of, of basically of the male organ. So, okay. Okay. And just want to go to this top question. Um, Jeffrey Ogden was clarifying that he's specifically in his own private practice, credentialed via ACP, and he is the decision maker. And this is the person who was speaking earlier about whether or not he could bill for for the gallstone
Oh yeah. Yeah. Then I
point of
would.
care.
Yeah, I would.
Okay. Okay, great. And Ruperdala, also in private practice, and she's asking about cost versus quality of image.
Um, so I mean, specific like handheld, like, well, so I'll say this, like, um,
She was asking about the MSK US. Would you recommend, is there a specific machine that you would recommend for a beginner in MSK US?
oh,
And
yeah,
she added that extra info that she's in private practice and is curious about cost versus quality of image.
so yeah, then I would stick. So the GEV scan, and this gets a little technical, like, so uh, the handhelds of like um of Sonosite and GE and Clarius, they all employ traditional technology, which is based off of crystals. You don't need to know any more than that. That's traditional technology, and that provides amazing image quality. So whether you have a traditional cart-based machine or you have a handheld GE or Sonosite that's hooked to your iPhone, the image quality is going to be the exact same. Obviously, the screen will be a little bit smaller, but it's going to be a ton cheaper because it's just that one single probe, maybe two, depending on the what you get. Um, the issue of image quality comes in with Butterfly, because Butterfly, however they did it, to put basically all probes into one. The image quality is not. I mean, it's definitely getting there. It definitely is doing a great job. Like, and I would probably say if you're looking to do other things, outside of MSK, then maybe consider the Butterfly. But otherwise, like, uh, look at GE or Sonosite and or Mindray and whatever handhelds that you like, that are most cost effective. And again, they should be like 5,000 or something. Like a handheld linear probe um, will be would be exactly what I would use if I was in an outpatient setting, or even in the ED. Like, I'd want a linear probe, and if cost was an issue, um, yeah, like right now, if I had a choice myself, I would say get the GEV scan with a linear probe, and you're off to the races. And you'll have, again, unless you want, but even then, you could put it on your iPad and the screen will be big. And um, yeah, that's what I would use in a second.
Thank you, doctor. Um, yeah, and then this one is from Thomas Vance. Where would you recommend an experienced NP or physician's assistant to start in their training? I'm currently in internal medicine and ER as well. It's from Thomas Vance.
Um, you know, uh, I would say, well, one, I mean, are they, because our APPs have asked this, and ultimately it came down to what our chair was willing to credential them in. So, it started with like soft tissue, bladder volume. I forget. There was a couple other ones. And then we train them, and we set, for emergency medicine, we set, you have to do 25, and we QA them, and give feedback. And that's how we did it. So I mean, you're kind of bouncing between IM and EM, which you'll have different, obviously, credentialing. Um, so it'll be, you kind of fall into that specialty specific departmental type of, EM, they might say, hey, yeah, you can do this, that, and the other thing, but IM may say something different. So, like, I would caution you there to, like, just make sure you're not, that you're credentialed to do whatever you're doing. If you have faculty that are already teaching it in either department, that's where I would start. Like, because I would just collaborate with them, because then you can, because the thing I like, you can go to a conference and you can spend a day and they inundate you with 20 different types of scans that you get 5 minutes on the probe, and like, you can't retain anything like that way. Like, you really, the way we did it with our APPs, were like, we started again, it was, I think it was bladder volume, soft tissue, and I just can't think of the other one. We started with just three, like that. We just high yield over and over again, train them, and then credentialed them that way. They didn't have to pay for anything. So, again, you can go to your um, um, specialty societies for all these conferences and stuff like that. But I think if you're able to do it locally within your department, that's going to be the most high yield way. It'll be the most cost effective way. And then you're seeing what your department's going to credential you in. And once the APPs, again, it's not like we have this very old school mentality in medicine that we have to stay in our wheelhouse, like, and we can't do something like, but anybody can learn a point of care if they want to. So the way, like, we started small with the APPs, they proved that they could do that, and then we slowly expanded it from there. Um, yeah, if you can start local, do that. Otherwise, yeah, you can look into, your national organizations as far as training. It just, they're limited because they try to squeeze everything in one day, and I don't know how anybody benefits from that. And I've been guilty of helping train, like, teach at those ones, and you're just like, how, like, what is anybody getting out of this? So that would be my approach. Try to keep it local and find someone to collaborate with within each department.
Thank you. From Jeffrey Ogden, is there any difference in liability insurance? Would I need a special waiver?
No, as long as you're credentialed, if you're credentialed in something, the liability and you're covered. Then it's just when you're doing stuff that you're not credentialed in. So, like, when we finally started doing transesophageal, we had to get credentialed, so our credentialing was updated when we did that. But had we been doing that, um, not credentialed, that could have opened up. Um, some liability there. But as long as you're credentialed, um, then you're safe.
Great. From the resident Carmen Kahina, thank you. Great discussion.
Yeah, of
And
course.
from Ahmed Abu Zaid, and I think you kind of answered this already, but he's asking about POCUS for PAs, for physician's assistants. You kind of covered that, but is there anything else you'd like to add there? Or
Yeah, no, I mean, I kind of used APPs broadly there for PAs and NPs. Like, there's no reason for you guys not to be doing this. It's the right thing for patients. Again, I don't know of any national guidelines or anything like that. I mean, you might want to look, in some of your PA societies, and I know there's a couple really good APP websites out there. I just don't have them offhand right now, like, that really, go into detail with POCUS and training and stuff like that. Yeah, there's no reason not to do it. I would just, again, wherever you're practicing, it just falls under credentialing, and try to train locally, just so you just get the numbers, because to go to a single conference is not going to get you there. But if you have a training program set up in-house, and start small, be like, hey, all I want to do is put IVs in, or all I want to do is make sure it's not an abscess. And that's exactly how we started with our PAs. They came to me and I was like, let's do it all. But then our chair was like, all right, let's settle down. And again, we started small and proof of concept. So there's no reason. And in fact, Penn has an APP. I think it was last year for the first time that they did the ultrasound fellowship. Yeah, it's the more the merrier is my point. But again, and as long as you're credentialed, because I know obviously not everybody's like the more the merrier. As long as you're credentialed locally and have good training, that's the most important thing.
you. And this last question, we don't have much time left, but this one's from Charlie Smithson. Have you used Clarius, specifically L20, the L20 handheld? Have you used that? And what's the quality of the image?
I don't know if it was the L20 or not. I have used Clarius. I actually took it with me. They gave me a loaner I was doing, like, a critical access hospital out in Montana. The image quality is great. Because again, it's that has the traditional technology. It's crystal based. So, the only difference, again, it's just you just get one probe. It's on your smartphone and stuff like that. So like, but they're like, um, yeah, I would encourage you to look at, a few handhelds before you just jump the gun, because you might have small little preferences here and there as far as how it feels or the weight of it, or it could be small little things. And believe me, all of these ultrasound companies like Point of Care will be fawning all over you. They will be knocking down your door to show you their product, to give you a demo, to let you demo it for a few weeks, because they want it out there. And if you start using it and tell the next person and the next person, so. But yeah, I would say the only one is Butterfly is the only one that has like, questionable image quality at times. It's usually pretty darn good, and it overheats. Otherwise, yeah, the other ones are all pretty traditional, and you know, pick the one that makes most sense for you, and try a couple out. Like I said, they're going to be jumping all over you. There's wherever you're at, there is a regional um manager and salesperson that oversees them. Like they constantly are calling and texting me when they come out to Philly to stop at Temple. So yeah, don't just jump on one. Look at a few and see what works for you. But I think any one of them is a good option.
When they demo the product for you, do they teach you how to disinfect it also? Do they walk you through
But
that part?
Yeah, I mean, so the vast majority of disinfecting is low level disinfectant, meaning if you're just doing a gallbladder, you just got to wipe it down with like, like a bleach wipe or something like that. It's when you get into invasive stuff, like, if you're putting IVs in, and this also somewhat falls into local guidelines, what your health system wants. But like anything invasive, we have to put a sterile probe cover on. So like any of our IVs has to have a sterile probe cover. And if they get blood on it, then they have to go to high level disinfection. And that's again, hospital policy. Like, but if you're in a clinic or just running around and you're just doing a transthoracic echo, anything that's non-invasive, you just wipe it down with whatever is approved by the manufacturer, and they're all pretty similar. Like all any of those gray wipes, purple wipes that you have lying around the hospital, they all count. The only time you have to really worry about it is if blood gets on it, um, or it's a like um, intracavitary one, like whether female pregnancy, pelvic, or
Mm.
transesophageal. But again, you don't have to. Um, yeah, that's really a non-issue when for the vast majority of scans.
Well, Dr. Gibbons, thank you so much. We have come to the top of the hour now, and this concludes our time together. It was so wonderful to listen to you and to learn. And thank you so much for your time tonight.